Hi, everyone. It is a pleasure to be with you today for the lecture on cartilage and bone. Let's get started. I'm going to share my screen. Before I get started, I wanted to point out that many of the slides were provided by Professor McNeil and my colleague, Dr. Mike Brown. Okay, so today we're going to describe cartilage structure and how it's formed. We are going to compare and contrast the extracellular matrix in different types of cartilage. We will chart macroscopic and microscopic organization of bone. Then we will compare and contrast the structures and functions of bone, the cells, in the context of normal matrix maintenance. Let's take a look at connective tissue specifically. Remember, there are 4 types of tissues actually, right? There are connective tissues, epithelium, muscle, and nervous. So of the connective tissues, there are 3 principal types. You have seen connective tissue proper and fluid connective tissue. In connective tissue proper, you look primarily at the fibroblasts, which produced mostly collagen tissue, and these were arranged either in a loose manner or in a dense manner. And remember that we looked at the relative ratio of cells to fibers in these 2 types of subclassifications of connective tissue proper. You also looked at blood connective tissue, and you've seen blood cells quite a bit now. You might think, well, why is blood part of connective tissue? Remember that it is derived from the mesenchymal stem cell, just like the fibroblast. So the supportive connective tissues include cartilage and bone, and they are very different in how they look and in their particular functions. I look at connective tissue proper as more as a filler, like a packing peanuts type of function. They also form the function of providing barriers to structures, containment. Blood functions as a tissue to transport oxygen, nutrients, toxins, carbon dioxide. Lymph is transferring a watery substance throughout the body. So definitely different functions between the different types of connective tissue. All right, so in connective tissue, you have cells which produce the extracellular matrix. For cartilage, our connective tissue is primarily, our connective tissue cells are chondroblasts and chondrocytes. Chondro is the prefix for cartilage. Blast is the suffix for relatively undifferentiated cells. And cyte is the suffix for more differentiated cells. Blast could also refer to progenitor cells, which is the case here actually. Bone has osteocytes, osteoblasts, osteoclasts, bone lining cells, and osteoprogenitor cells. Put an asterisk next to osteoclasts. They're a little bit of a different type of bone cell, and we'll discuss that when we get to that part in the lecture. As far as the extracellular matrix is concerned, connective tissue has collagen fibers, elastic fibers, and reticular fibers, all of which you have seen. In cartilage, we have different types of collagen and elastin, and to a lesser degree of reticular fibers. The ground substance, particularly in cartilage, consists of glycosaminoglycans, proteoglycans, and glycoproteins. Bone has this type of ground substance as well, but its ground substance calcifies, which makes it look and feel different. In a cartilage, these glycosaminoglycans are soaking up water like a sponge, which gives cartilage its characteristic spongy type morphology. So the classification functions of these connective tissues, including cartilage and bone, are based on the differences in the composition of the cells and the fibers and the ground substance. And cartilage and bone are no different. They just have a specialized role in their as far as their function in the body. So let's take a look at a couple pictures that distinguish cartilage from bone. The first thing you should note is that they look really different. The picture on the left is of a biopsy of cartilage, part of its perichondrium. peri meaning around, chondro meaning cartilage, so the surrounding dense irregular connective tissue, which in this H&E stain, of course, stains red because it has a lot of type 1 collagen in it. Notice that the squishy part of the cartilage is very blue. It's very basophilic. It has a lot of negatively charged molecules, and so it attracts the basophilic stain and looks blue. In this case, it looks more like a lavender to me. The other thing you should note from the morphology is that we have these big bubbles that are actually the nests, or what we call lacuna, of the chondrocytes, and to a lesser extent the chondroblasts. But notice that they twin, like there and there, and that's a very characteristic look of cartilage. These cells are relatively small. If we look over to bone, this is a much more magnified view of a tissue biopsy. So these two are not of the same magnification. And I know that because I don't see the periosteum on this image in the bone. But what I do see at a higher magnification is this circular structure. It looks like a cross-section of a tree. I like to think of it as a cross-section of a cinnamon roll bun. And that cinnamon roll has raisins in it. Raisins and cinnamon rolls go along really well together. And so the raisins represent the osteocytes that are trapped within the bone. So let's take a look at cartilage first. Now I have this x-ray of two hands from two different people that are in relatively the same orientation. The left image is an x-ray of the bone, and bones in the hand, and the right image is the same thing, but there's something very different about these two hands. So I want you to stop the video and consider for a moment what the major difference is between these two x-rays. Okay, welcome back. So there's a lot of things that are different between these two x-rays, but I want to point you to something in particular, and that is right here. So this red arrow is showing what looks like a fracture to be in the proximal ends of almost all of the phalangeal bones. You can see that that does not show up on the image on the left. In fact, what's left on the image on the left is this line where before there was a gap. So the image on the left is a picture of an adult hand x-ray and normal x-ray. And the image on the right is of a pediatric x-ray. Now, again, there are other things that hopefully you noticed on these images, and you can try to come to those conclusions on your own. But this line here is super important. That is where the growth plate is. And that growth plate, which we will talk about more in the next lecture, is filled with cartilage. So the real question is, why does it show up as a dark line? Well, bone is radio opaque. In other words, it shows up on an x-ray because the particles of the x-ray can't go through the bone as readily as they can go through structures that have a high amount of air, or in this case, a high amount of water. And remember that cartilage is a specialized tissue to hold lots of water. That's what its glycosaminoglycans are doing. All right, so let's take a look at some characteristics of cartilage. Cartilage is semi-rigid. It's definitely weaker than bone. In fact, if you go back to that x-ray, every place where you saw a growth plate is an area where the bone as a whole can fracture because it doesn't have the solid calcification. But that gives way or allows the tissue to be flexible and resilient due to the elastic and collagen fibers that are contained within the ground substance. So it feels like jelly. And the best analogy I can think of is for any of you who run on Asics running shoes, ASICS running shoes have in their midsole a little gel packet, which makes the midsole really squishy. That's a good analogy. Or gummy bears might be also a really good analogy if you haven't noticed. All of anatomy relates to food somehow. So, but the squishiness of a gummy bear is kind of analogous to bone or to cartilage. One of the most important features of cartilage is that it is avascular. So you might be wondering, well, how do the cells stay alive? They actually receive their nutrients and oxygen through diffusion. So through the perichondrium all the way down into the squishy cartilaginous substance. And that has some important clinical implications, which we'll see later in this lecture. So given these characteristics, what is cartilage useful for? Well, it helps support soft tissue. It forms a nice soft substance and capsule for articular surfaces of joints. And we'll take a look at, in the next lecture, it provides a model, a framework from which endochondral bone can form. So there are three types of cartilage. The one that you're probably most familiar with is hyaline cartilage. Hyaline cartilage is flexible and resilient, and it's located in many different places, notably the respiratory system. When we talk about the tracheal cartilages or the bronchial cartilages, those are all hyaline cartilages. Costal cartilage, which you can feel on your rib cage, they're soft here. They allow the ribs to rotate, to expand the rib cage and to contract it during the breathing cycle. The cartilage in your nose, you can feel that right there. Your articular cartilage, which is on the surfaces of your bones in your joint cavities, those are the ones that typically get injured, and we tend to complain about those all the time, especially as we get older, or if you are into sports and have injured your cartilage, you know what articular cartilage is. The epiphyseal plate, which is our growth plate, is comprised of hyaline cartilage, and the fetal skeleton has a great amount of cartilage. The fetal skeleton uses that hyaline cartilage as a model for intramembranous ossification in addition to endochondral ossification. Another type of cartilage is elastic cartilage. It contains elastic fibers in it, hence the name. It provides a little bit more flexibility than the hyaline cartilage, also a little bit more resiliency. So the two places where you're going to see a good amount of elastic cartilage is the epiglottis, which is the barrier to the laryngeal inlet into which air goes through, and the external ear. And you can feel that right here. Notice that my ear bounces back when I tug on it. The last type of cartilage is the fibrocartilage. Now this one contains really thick collagen fibers. It's a really good shock absorber, and it's found in the outer rim of the intervertebral discs, the menisci of the knee, and the menisci of the jaw, the so-called TMJ or temporomandibular joint, and the pubic symphysis. So going back to my running shoe analogy, in an ASICS gel shoe, I would call the gel packet a hyaline cartilage, which is analogous to the nucleus pulposus in an intervertebral disc, and the midsole of the shoe as the analogous to a fibrocartilage, the white part of that sole. So in the middle you've got your gel packet, and then on the outside you have your midsole. That's analogous to the annulus, a nucleus pulposus of the intervertebral discs in the middle, and the annulus fibrosus of the intervertebral discs, or the fibrocartilage part surrounding that natural gel packet. Okay, so we have three different types of cartilage with different functions. So we would expect to see three different types of morphologies, and that's exactly what we see. I want to direct your attention to the cartoons at the bottom first. So the first thing you should notice is that we have cells that are sitting in their lacuna. The cells are the little dark parts here, and they are well, they kind of look like candy corns to me in a funny way, at least in terms of their stripes and morphology. But so we'll go with candy corn. So we have a bunch of candy corn lacuna with chondrocytes located in them. You'll notice that we have that in all three types of cartilage. But there's some differences in how they're arranged. And what I want you to notice is that in fibrocartilage, these lacunae containing the chondrocytes in the lacunae are arranged in rows, or in this case, sorry, columns. Whereas in elastic cartilage and in hyaline cartilage, they seem to be more randomly arranged. The next thing you should take a look at are the fibers. In hyaline cartilage, we have fibers that are scattered throughout the ground substance, but in elastic cartilage, we have the very dark, characteristic elastic fibers that are within the ground substance. And then in fibrocartilage, we have these thick bands of collagen that are placing these chondrocytes into rows like that. All right, the next thing you should notice is what's going on in the perichondrium. You'll notice that in the hyaline cartilage and the elastic cartilage, we have a perichondrium. There's no perichondrium in the fibrocartilage. These cells here are representative of mesenchymal stem cells and fibroblasts. You can't tell the difference between the two in this particular cartoon, and you would be hard-pressed to tell the difference in an H&E stain as well. But what we do know is some of these cells that are actually mesenchymal stem cells are going to differentiate into chondroblasts, and you can see that represented here by this row of 4 cells under hyaline cartilage and elastic cartilage. Note that we don't have the same type of arrangement of cells in the fibrocartilage. So if you look at the actual histology, you can see our ground substance with our lacuna and containing the chondrocytes in both hyaline and elastic cartilage. In elastic cartilage, we have some darker staining fibers. There's some better stains of this in other pictures. And then fibrocartilage, we have our chondrocytes arranged in rows. This doesn't happen to show very many chondrocytes, but we have lots of collagen bands that are forming the columns. All right, so let's take a look at these in a little bit more detail. The lower right here is a vertebrate fetus, and the cartilage model is staining in blue, so you can notice that there's lots of cartilage, and the red part is the part that's starting to ossify. So again, it's hyaline cartilage is a specialized cartilage with a highly hydrated matrix. And again, it's the glycosaminoglycans, the glycoproteins in general, the proteoglycans that are soaking up water like a sponge based on their charges. It forms the basis for fetal skeleton development, and it can calcify during the aging process. So in this cartoon, we can see the different areas that I pointed out in the previous slide. We'll start again with the ground substance area. Here are chondrocytes that are located in their lacunae. Again, they kind of look like candy corn to me. The twinning part, which I referred to earlier, is called an isogenous groups, and I'll explain how it gets there in a second. We have some lacunae without chondrocytes. That is typically either artifact or the slice through the tissue didn't actually capture the chondrocyte. Then we're going to talk about territorial matrix and interterritorial matrix in a second. But then to end off, as far as the tissue layers, we're looking at a perichondrium that by convention in this image is at the top of the picture. But remember, cartilage actually has 2 sides. So, and so there could be a perichondrium on the bottom over here if we extended the picture. So let's talk about how we get to the isogenous groups first, then we'll talk about the matrices. So again, remembering that perichondrium, this is comprised of a dense, irregular connective tissue, which has fibroblasts in it since it's producing type 1 collagen. And then we also have mesenchymal stem cells, which will differentiate into our chondroblasts. And our chondroblasts, which should be labeled but are not, are located here, representing in the picture. And what is happening is that they are laying down matrix. And we'll talk about the composition of matrix in a bit, but they're laying down that matrix. And as they lay down their matrix, they're being pushed away from the perichondrium. So what that means is that these chondrocytes and lacunae, down here at the bottom of the image, are older cells than the chondrocytes or even chondroblasts towards the perichondrium. So they're literally migrating down into deeper and deeper into the ground substance. The matrix that they produce is classified as two different types. The territorial matrix is the matrix that immediately surrounds the lacunae, and it's the densest part of, or I should say, has the densest amount of glycosaminoglycans that are soaking up the water, and other molecules that are doing that are part of that. So it tends to stain darker purple, and that's because there's a higher concentration of those molecules. The interterritorial matrix is just the more diffuse part of that matrix between the isogenous groups, right? So going back to the isogenous group, as a chondrocyte migrates down deeper into the matrix, it twins. And so an isogenous group is the twin, or the two twins, or the two daughter cells that came from the original chondrocyte. Typically, as far as we know, our chondroblasts are dividing into different chondrocytes. But once a chondrocyte is differentiated, it can only divide once, and it forms that isogenous group. And then it's done. It's done dividing, as far as we know. Okay, now if we take a look at elastic cartilage, really the only difference between elastic cartilage and hyaline cartilage is the fact that it has elastic fibers, an abundance of elastic fibers in its ground substance. The other thing too is, as I mentioned before, elastic cartilage tends to be located in specific places. Here is the epiglottis, which I referred to as the lid of the laryngeal inlet. When we breathe, air comes in through our nasal cavity, into our nasopharynx, into our oropharynx, and into the laryngeal inlet down this way. When we eat, we take in food or drink through the oral cavity. It goes into the oropharynx, down the laryngo or hypopharynx, and into the esophagus. So what the epiglottis does is it closes the laryngeal inlet so that food and liquids don't enter into the airway, which we all know what happens when that does. We cough incessantly because we don't want anything to get into the airway. Something to keep in mind is that the fibers and sheets of the elastic fibers give this elastic cartilage its elasticity and its resiliency. And you need a special stain to see the elastic fibers. And you might remember what that stain is. Okay, and finally, if we take a look at fibrocartilage, so what we're doing here is we're combining a dense amount of connective tissue and a hyaline cartilage, like super dense amount of connective tissue. So here is our connective tissue here. Most of it is type 1 collagen. Notice again, there's no perichondrium in fibrocartilage, and it resists compression and shearing forces, and it acts as a strong shock absorber. What's shown here on this image is the pubic symphysis, the fibrocartilage that's there. Just as a little clinical tidbit, when a pregnant woman is in her 3rd trimester, towards the end of the trimester and going into labor, her body secretes a hormone called relaxin. And relaxin actually softens the fibrocartilage. And the secretion of that hormone starts long before actual delivery. But that's also one of the reasons why women complain of back pain, because remember that fibrocartilage is forming the annulus fibrosus of the intervertebral discs. And if those soften to become not quite as soft, but softer like the nucleus pulposus, then the vertebral bodies will tend to squish together, which causes a lot of discomfort and pain. Nevertheless, we talked about type 1 cartilage in the perichondrium of the hyaline cartilage and the elastic cartilage, and located here in the matrix of the fibrocartilage. But there's also type 2 cartilage, and that is what is staining primarily purple. I'm going to go back to these other two slides. That's what's primarily staining purple in the ground substance of the hyaline cartilage and in the elastic cartilage. So we have two principal types of collagen: type 1 in the dense connective tissue parts of the cartilage, and type 2 in the watery ground substance parts of the cartilage. All right, so this table summarizes it very nicely. You can see here three different types of cartilage: extracellular matrix, the chondrocyte arrangement, the perichondrium, the locations, and the functions. Tables are really nice way of summarizing information. I wouldn't go so far as to say to memorize the table, but what I would highly recommend is that you become familiar with this table. Tables are also really good frameworks for creating flashcards to be able to quiz yourself as you go through the material. So I encourage you to use this table a lot. Okay, so let's go into a little bit more detail about the cartilage structure, which I summarized just a second ago. Remember, we have chondroblasts and chondrocytes as cells, and then we have an extracellular matrix, which is formed of a ground substance, or gel or jelly-like ground substance, and this is all contained within a perichondrium. So our matrix is staining purple in this hyaline cartilage. We have our chondrocytes within the lacunae. Here's our pink perichondrium of dense irregular connective tissue. And you can see here's a chondroblast that differentiated from a mesenchymal stem cell. And remember that the chondroblasts are going to differentiate into chondrocytes as they push away from the perichondrium and get buried into the extracellular matrix. All right, here is the cartilage composition. I just want to mention that this mentions that there's lots of different types of collagens, but the principal collagen that you should be concerned with is a type 2 collagen within the matrix. It's incredibly important that you remember that cartilage is avascular. That means the matrix itself lacks sensation, although there are some nerve fibers in the perichondrium. So we're talking about two different things. This is the cartilage matrix itself, all right? The perichondrium can have some nerve fibers, which is why menisci hurt when they're torn, right? Those fibrocartilages. It lacks lymphatic vessels. Basically, the movement of fluids, nutrients, toxins in and out of the cartilage matrix has to happen only through diffusion. The mechanical stress on the cartilage helps keeps the fluids moving so things can diffuse easier in and out of that matrix. Due to this cartilage composition of cells, glycoproteins, proteoglycans, again, glycoproteins and proteoglycans are the ones that are soaking up the water. The collagen itself, and this huge amount of water, it's able to bear mechanical stress. Now it forms the primary framework or template for bone development. So hopefully that explains why cartilage is really good for support, movement, the mediation of the growth of long bones, and it resists compression. Okay, so now let's talk about the perichondrium. The previous slide was on the matrix, the cartilage composition of the matrix. This is the perichondrium. So the perichondrium, this pink layer here, has two parts. It's a dense, first of all, the whole thing is a dense connective tissue. It's a dense irregular connective tissue. Articular cartilage and fiber cartilage do not have a perichondrium. I mentioned earlier that fiber cartilage doesn't have a perichondrium, but I didn't mention that articular cartilage, which is a hyaline cartilage, also does not have a perichondrium. In this perichondrium, we have two layers. We have an outer fibrous layer, which again is mostly collagen fibers, and we have an inner cellular layer, which are the cells that have differentiated from mesenchymal stem cells that are moving towards the matrix, right? And you can see that in that picture that we saw earlier before, okay? So let's talk a little bit more now about the extracellular matrix composition. Here you can see how it's stained purple. I like this slide a lot because it shows the really darker purple territorial matrix and the less darkly staining purple interterritorial matrix. It has a large ratio of glycosaminoglycans, the type 2 collagen fibers, which is what is soaking up the water, and I've referred to that before. Note here, here's a bullet point on the perichondrium. The perichondrium is highly vascularized. It's the extracellular matrix that's not highly vascularized. This shows it really well if we take a look at the matrix, the really deep purple territorial matrix here, and the more pale staining interterritorial matrix. Here again is an isogenous group. This one actually had triplets. So, but basically the isogenous groups look like twins, like what we see here. All right, so you might be wondering, where do the lacunae come from? Well, and you can see them here as well. There are these, these clearings. They're actually artifactual. The chondrocytes themselves actually fill up the entire lacunae, but because they shrink during the tissue processing, it looks like that they are, the cells are quite small, which leaves these massive holes. So that's actually an artifact, but it's a good distinguishing feature that we can use for cartilage. So we already talked about the capsular matrix. We were talking about the territorial matrix, the interterritorial matrix. Let me just say something more about the capsular matrix. So you don't need to worry about the capsular matrix, but it is, if we take a chondrocyte, immediately surrounding one chondrocyte is the capsular matrix. It's really difficult to see on a slide. So we're sticking with just being able to see territorial matrix, again, which is that dark purple, and the lighter or less purple interterritorial matrix. All right, so I've been alluding to this for some time now. What is in that extracellular matrix? This is a high magnification cartoon now. Here are our chondrocytes that are located in our isogenous groups. And we have the really big collagen fibers that are represented by these big licorice looking things here. All right, and the collagen fibers in the matrix is primarily type 2 collagen, especially for our hyaline and our elastic cartilages. So all these other fibers, what are they? Well, they're proteoglycans, and proteoglycans consist of hyaluronic acid, aggregans, chondroitin sulfate, keratin sulfate, sulfate groups, basically things that have large negative charge. Again, that's why our matrix stains purple, because it's a negative charge substance, and water has a dipole charge. It has a positive charge towards a net positive charge towards the hydrogens and a negative charge towards the oxygen. So water is really drawn to proteoglycans. And then we have other glycoproteins between the cells and the matrix. So here, the proteoglycan and the hyaluronic acid are shown here. I believe we have a enlarged version of this. Here we go. All right, so here's our type 2 collagen fiber. Again, it kind of looks like a big licorice stick, if you will. And here's our proteoglycan. It, to me, looks like a bristle brush that you might clean out your environmentally friendly metal straw. The hyaluronic acid is the main branch that connects all of our different bristle brushes. So let's take a magnified view of one of the proteoglycans. Here you can see the hyaluronic acid, main backbone of the entire water absorbing molecules. The core protein extends perpendicular to the hyaluronic acid, and from that, perpendicular to the core protein, parallel to the hyaluronic acid, are the bristles of the brush. And the bristles are comprised of chondroitin sulfate. All right? There is a linking protein that connects all these different branch points, but the bottom line is that this chondroitin sulfate and the proteoglycans all together have a really strong negative charge, which soaks up the water. In fact, 60–80% of the net weight of the cartilage is water because it is attracted to all this. Again, think of that ASICS gel packet that is in your shoes. And by the way, if you run on Nike, it's the Nike Air packet, but the analogy doesn't work as well for Nike. So ASICS gel. Maybe you'll all start buying ASICS gel shoes now. Okay. Okay, so now let's talk about how cells grow, and I've alluded to this already, but there are two different types. Appositional is when the cartilage cells are dividing in that cellular layer of the perichondrium, and they're moving down towards the matrix in this direction, or you can think of it as pushing away the perichondrium. So they're dividing that way. But again, remember, once a chondrocyte has differentiated and finds itself into its matrix, it undergoes what's called interstitial growth. And this is a mitotic division into an isogenous group. Again, typically we see the twinning. I don't know for sure if it just stops at one division. It may or may not. But from a visual standpoint, that's what we see. We see our twins, or in this case, this one had quadruplets. Okay, so what happens if cartilage gets damaged? How does it get repaired? Remember that cartilage is avascular, so that presents a big problem, because that means that the body can't send stem cells, it can't incite an inflammatory reaction, it can't undergo a wound healing process that we normally see for other tissues of the body. So here we look at normal cartilage at the top, which has its nice perichondrium layer, and then the extracellular matrix layer, right? But this is an osteoarthritic cartilage where the cartilage is clearly damaged. It's lost its structure. If we look over here, this now refers more towards a fibrocartilage structure. This is the intervertebral disc. The nucleus pulposus is that gel packet of type 2 hyaline cartilage located within the intervertebral disc. The surrounding shown at the top and at the bottom, and in a normal disc all the way around. That's our fibrocartilage that, again, has a lot of type 1 collagen in addition to the type 2 collagen, but a lot of type 1. When that fibrocartilage breaks down, then the nucleus pulposus can protrude. And typically when this happens, we talked about this in the context of nerve impingement. Some of you might know that as colloquially as sciatica, but this is what's going on here. So how does this thing get repaired? Well, the answer is it doesn't get repaired very well. The cartilage, hyaline cartilage in particular, that's what gets injured quite a bit. In this case, down here in the lower left, the fibrocartilage, it doesn't receive a whole lot of blood supply. So what's it going to do? Well, that's where some surgical intervention comes in, or pain management comes in, because there just isn't much you can do about this cartilage. So one possible thing that has been innovated, which works for some people, but maybe not for others, is a procedure called microfracture. And what you see here in this image, and there's lots of YouTube videos, I just happen to list one of them here, lots of YouTube videos you can watch about microfracture surgery. What you're seeing here is an arthroscopic view of an articular bone, a part of the bone. Here is the cartilage, the articular cartilage in the joint space. Down here is the articular cartilage on the adjoining bone. And what you can see here is there's no cartilage in this region here. And the surgeon has actually taken an awl and poked holes into the epiphyseal bone. What is leaking out is blood. And the idea here is to have blood with its mesenchymal stem cells circulating through here to seed in this region and start forming cartilage by introducing our mesenchymal stem cells, which will differentiate, hopefully, into chondroblasts to form the cartilage. This procedure, again, works for some people, but not for others. But you can imagine that the theory behind the science of getting cartilage to repair. Okay, so what we'll do now is I'd like to take a little quick stretch break, and then we will come back and talk about bone. Okay, hopefully we're back. We're going to talk about bone now, so I'm going to share my screen again. All right, so here's an x-ray of two pelvises. What I want you to notice here is that these are from two adults. One is from male and one is from female. Take a second and decide, pause the video and decide which one you think is male and which one is female. All right, what you should have noticed is that whenever we look at radiology, we look at both sides always. These have typically, the L is listed on this side over here, but this is a typical radiological view where right is left and left is right. But that little letter tells you what's what, but that actually really doesn't matter too much for our exercise. What I do want to mention is that here our pubic arch is a little wider, and so that designates that this is a female pelvis, and here the pubic arch is relatively narrow. That designates that that is a male pelvis. The other thing that helps is that the pelvic outlet right here, actually down here, and the pelvic inlet, which is what I outlined, is typically wider in a female. Okay, now if this were a pediatric image, then we would expect to see a growth plate, right? And why? Again, because cartilage is watery and it's not as radiopaque. So if this was a pediatric bone, then you would see a line right here at the neck of the femur on both sides. All right, so let's talk about bone. Bone is hard, right? That's the main difference. Bone is hard and it gives a lot of structure. The connective tissue calcifies, which is what makes it hard. And that the organic part of that extracellular matrix is called osteoid. The calcified part, or the inorganic component, is called hydroxyapatite, and it is comprised of calcium phosphate and calcium carbonate. So the nice hard structure of bone gives a good framework for our muscles. It does cause some issues if we have fractures. But the nice thing is bone is highly vascular. So we're able to repair bone much easier than we're able to repair cartilage. As you can see here, the main cells for bone is called the osteocyte. So osteocyte is to bone, as chondrocyte is to cartilage. So because bone is hard, what is it good for? Well, it's a really great framework for the body, which I mentioned. It protects vital organs. It facilitates movement. You should always know that bones can't move themselves. You got to have muscles that cross the joints to be able to move the bones. Something we don't always think about, but is very, very important, is that the cavities of bones, the marrow cavity, particularly red marrow, which you can see here, is the site of hematopoiesis. This happens to be an epiphysis. This has a little bit of yellow marrow, which will increase over age, and that is the fat that starts to build up in the marrow cavity as an individual gets older. Now, with all that calcium in the bone, it is the biggest reservoir for calcium for the body. So if we need calcium, we can just resorb it from the bone and put it right back in the bloodstream. We'll talk about how that happens in a little bit. There's lots of different bones. I know you can read this on your own, but basically it's classified by shape. We have long bones, short bones, flat bones, irregular bones, sesamoid bones, all sorts of different kinds of bones. And they all develop basically from two different mechanisms. They either, for the most part, flat bones develop from what's called a process called intramembranous ossification. And long bones develops from a process called endochondral ossification. And again, we will talk about those in more detail in the next lecture. So here's a flat bone. What's important to understand about flat bones, in the same way that we were looking at hyaline cartilage, is that there's two surfaces of the bone. And in all the cartilage pictures, I can only show you one surface based on the biopsies that I had available for the pictures. But the periosteum lines the bone on the external surface. Then within the bone itself, we have two different layers. We have this spongy middle layer and then a compact outer layer. So from superficial to deep, we have a periosteum and then a compact bone and then a spongy bone, like that. Now, the compact bone is lined by the periosteum, so it's lined on this side, right? The spongy bone, though, is lined by a layer called an endosteum, which is more of a cellular layer. Both of the compact bone and the spongy bone have osteons within them, but the osteons are much more prevalent and visible in the compact bone. The spongy bone osteons are arranged in trabeculae, so they like wind through the spongy bone, so it's harder to see an osteon type structure within the spongy bone. The spongy bone also, as we talked about earlier, often contains red marrow, and in older individuals, yellow marrow. All right, so these are the main anatomical areas of a long bone. And I believe these are animated. Right, there we go. Okay, so the numbers refer to the numbers shown here on the image. So compact bone, or bone collar, I will often call it, is the compact bone immediately underlying the periosteum. Oh, and by the way, periosteum is highly innervated, which is why when a bone breaks, fractures, it is incredibly painful. It's because of the nerves in the periosteum. The spongy bone is located deep to the cortical bone. Spongy bone is also called cancellous bone. Then we have the diaphysis and the epiphysis. So the diaphysis is colloquially known as the shaft, and the epiphysis is colloquially known as the ends of the bones. And of course, with a long bone, you have two ends, or two epiphyses and one diaphysis. The metaphysis, you're going to hear the word metaphysis used different ways throughout your career. So we're going to refer to the metaphysis as as analogous to the epiphyseal plate or the epiphyseal line if we're talking about an adult bone. So meta means change. So the metaphysis is right here. You can see this line on this part, and it's also shown right here. Right, that it was, at least in this picture, the resulting closure of the growth plate. You may also hear the word metaphysis as the entire region that transitions from the epiphysis to the diaphysis. And within the metaphysis is the epiphyseal plate. Both definitions in my mind actually work just fine. I actually tend to use the latter definition, where the metaphysis is the region of transition and the epiphyseal plate or line is the growth plate. Then we have the apophysis, and an apophysis is just an outgrowth of bone, like a tubercle, on which muscles attach. And the reason why the apophysis is even there is because of the force of the pull of the muscles. Children who are learning to crawl don't have too many apophyses that are readily palpable, but as they get older and then they start to walk, then you'll notice that those apophyses are starting to form because the muscles that are attached at those points have pulled and remodeled the bone to take that shape. We'll talk about bone remodeling in a minute, but it's a very, very cool process. Then finally, we have the articular cartilage, which again is a hyaline cartilage sans the perichondrium. And the articular cartilage is only found within the joint space on the epiphysis of the bones. We have articular cartilage on the proximal end and also the distal end. Okay, if we talk about the medullary cavity that is located here, it's the cavity, the space within the spongy or cancellous bone that contains the marrow. The endosteum is the cellular lining, which you can't really see very well, but it's there, at least you can't see it in this picture. It's the lining of cells that line the spongy bone and separates the spongy bone from the medullary cavity. And then finally, the periosteum on this image, that is that dense irregular connective tissue that surrounds the bone. And again, remember, it is highly, highly, highly innervated. All right, so I mentioned this already, but long bones are richly vascularized and richly innervated. We can see that here, where in a typical long bone, we have two principal sources of vascularization. The first is through the nutrient portal. And so here we have a nutrient artery and a nutrient vein, which are going in opposite directions, but they are perforating typically the middle of the diaphysis and branching throughout the medullary cavity. That's the primary vascularization. As you can see here, there's a lymphatic vessel as well that is located in the periosteum. Lymph tends to percolate from the osteons and the spongy bone structures and into the lymph vessels, which are located in that dense irregular connective tissue of the periosteum. Then we have the secondary vascularization portal, which is through here in this region of the metaphysis. So we have, actually here on this drawing, we have a metaphyseal artery as well, but this epiphyseal artery is what I'm referring to. So this perforates and supplies the secondary region of the bone, or secondary ossification center, we'll refer to it later, in the epiphysis. So the fact that long bones have two sources of vascularization, one to the diaphysis and one to the epiphysis, is actually consequential, particularly in pediatrics. And so if we lose the blood supply, the epiphyseal artery, as it's labeled here, if we lose this blood supply, then we also could lose the blood supply to the epiphyseal plate, or the growth plate, and that can have some serious consequences in developing bones. All right, so here is a cross section or a transverse section of a long bone. And what you see here labeled 1 is the outer surface. This is where the periosteum is located. We have some muscle and tendinous tissue located here in this corner, but this outer rim is mostly periosteum. And just like the perichondrium, it has an outer fibrous layer and an inner cellular layer. The fibrous layer has dense irregular connective tissue. Actually, so does the inner layer, but the inner layer has more cells located with it. And the cells, again, are mesenchymal stem cells, and also there's some fibroblasts in there, like I mentioned before with the perichondrium. But some of these mesenchymal stem cells are differentiating into osteoprogenitor cells, which will become osteoblasts. Then the inner surface of the bone in here, this part lines the bone cavity, and instead of being lined by a periosteum, the way to remember this is peri means around and endo means within. So the endosteum is a cellular layer that lines the bone all the way around these spaces and separates the marrow cavity from the actual bone tissue. There's only one layer of cells on that cavity, and these cells are often called bone lining cells. Sometimes they have osteoprogenitor cells, but for the most part, you can't really tell the difference between the two. So we typically refer to them as bone lining cells. All right, so let's take a look at the compact part of the bone. So this is what, again, I call the bone collar. Here is a long bone. Spongy bone is the stippled part of the drawing. The medullary cavity is the part that looks more like empty. It looks like a canoe, actually. The periosteum is the lining, the outer part of the bone. And the compact bone, or the bone collar, is the really dense part of the bone that is surrounding the medullary cavity, but contained by the periosteum. You can imagine if a human bone was filled completely with compact bone, our bones would be incredibly heavy. And so we don't want that, but we don't want structure either, or lack of structure, so we have to have a bone collar. And if you take a look at the picture on the right here, this is the compact bone or bone collar, and this is the spongy or cancellous bone shown here within the cavity. As far as cubic volume, obviously the cancellous bone occupies more space than the compact bone. All right, so what are the different parts? Let's take a look at the first, which is the osteon. And if you remember that picture that I showed you earlier with the cinnamon roll and raisins, this is what I'm talking about. The osteon in this transverse section here looks like a cinnamon roll or a tree trunk that's been cut, although I don't like to talk about trees that were cut, so I prefer to go with the cinnamon roll. This is the osteon. It's called a Haversian system because that Haversian system has a neurovascular bundle that is located within the central canal or the Haversian canal. You can see that right here. Here's the Haversian system. Sorry, here's the Haversian canal filled with the neurovascular bundle, but the entire cinnamon roll is called the Haversian system or the osteon. So the actual layers of that cinnamon bun are called lamellae. They're circular layers. Now they're actually not circles. They're more like twists that go through the osteon that allow the osteon to have some limited movement. The bones have to be resilient to some point, and so making them super strong and brittle is not the point. They need to have some give. So the osteons are actually more like a finger trap, if you will, in terms of structure that goes all the way up the shaft of the osteon. But they are circularly arranged, at least from this view, as lamellae. We already talked about the Haversian or central canal. So if we took a cut of this osteon and we looked at it down here, here is half our cinnamon roll, and here is our neurovascular bundle going along the long axis of that Haversian system. Now, the different osteons have to connect. So they connect via what's called a perforating canal. or a Volkmann's canal. In fact, this is how the perforating artery and vein get into the diaphysis of the bone. They go through a perforating channel. Well, these perforating channels branch and they connect the different osteons as well. The osteocytes, located in their own little lacunae, are the raisins that are in our analogy of a cinnamon roll osteon. Another way of looking at it is they kind of look like little spiders. They've got the little extensions that go into the little connecting tubules, called canaliculi. And that is not labeled here. We'll look at it in a different picture. Okay, so let's take a look at our osteon in a little bit more detail. So here is our osteon right up here, and you'll notice that the different lamellae, even though they're circular in one plane, they actually are located, there's fibers located orthogonal to one another. And again, this is what gives the osteon its ability to slightly move, but also have that resiliency and that solid structure. It's pretty cool. Bone is pretty, it's pretty solid. That that was a bad pun. Anyway, the osteons are also microscopically arranged. So the inner lamella is called the inner circumferential lamella. Then, of course, there must be, if there's an inner, there's an outer. So the outer circumferential lamellae is the last ring, the outermost ring. We distinguish that from these interstitial lamellae, which are the remnants of old osteons between the existing osteons. So it's you've got your cinnamon bun that is embedded in a bunch of older cinnamon buns that have taken over as far as their, if we carry that analogy too far. So the canals, remember, the vertical or long axis canals are called Haversian canals, and the cross-sectional or horizontal canals are called Volkmann's canals. Here in this image, you can see an osteon with its central canal in cross-section and a Volkmann's canal, which is connecting, in this case, 3 osteons. And remember, in those canals travel our neurovascular bundles. Okay, so that was compact bone. Let's take a look at spongy bone now. So just by way of orientation, here's our bone collar, our compact bone, with our osteons. So the osteon is the relatively newer arrangement of lamellae. Here's our interstitial lamellae, which are the older osteons. All right, this canal right here, it is a Haversian canal because it's within the long axis of that osteon. All right, so what's going on with the spongy bone? Well, the spongy bone, as you can see, are arranged sort of like osteons, but not really. They're not solid cylindrical structures, right? And if we look over here, the bone looks like it's forming a weave throughout this space, and indeed it is. It is comprised of lamellae that are going in multiple directions. We actually, in this case, call that that structure more of a trabecular type arrangement, as opposed to an osteon type of arrangement. It's still comprised of layers, sheets of bone. Now, what's interesting about trabeculae is that if we take a step back and we take a look at the general direction of the trabeculae, if I look at this picture on the right, you can see that it seems to form, there's an axis that's going from bottom to top, right to left. There's also seems to be a curve that's going from bottom to top, left to right in this direction, if you can see my arrow. What you see on the left here is that these trabeculae form tension cables. And so they are arranged in such a way that they can withstand stress in one direction versus another, which gives the bone its strength and resiliency. Pretty cool. Now, we're going to start talking about cells soon, and it's the osteoblasts and osteoclasts that are working in partnership but against one another to be able to help the bone maintain these structures, both the compact and the spongy parts of the bone. All right, so let's take a much closer look at one of these trabeculae. So in one trabeculae, which is, or trabecula, I should say, in one trabecula, here is a cross section of that. Notice it looks like an osteon, right? But again, by definition, an osteon has to have either a Haversian system or Haversian canal with neurovascular bundles within it, or it has to have a Volkmann's canal running across it. This one has neither. So it still has the circular lamellae of bone, as you can see here, but there is no neurovascular bundle going through the center of this trabecula. How do the bone cells receive their nutrients and also get rid of their waste and receive their oxygen and get rid of their carbon dioxide? It's purely through diffusion with the marrow cavity. And these little canaliculi, which means tiny canals, are perforating through from the outer surface into the lamellae. Now, the compact bone also has these canaliculi, but the difference here is the canaliculi in the trabecular bone communicates with the marrow cavity, whereas in the osteons, the canaliculi communicate with the Haversian or the Volkmann systems, or canals, I should say. Now, the osteocytes are located, just like in the osteon, within the lamellae, and that's what you see here, and they're sitting in their own little lacunae. Then we have the osteoclasts, and these are big, multinucleated cells that are roaming around and reshaping the bone. So the osteocytes and the osteoclasts are working, they are antagonists to one another in terms of building and resorbing the bone respectively. Osteocyte is building bone, osteoclast is breaking it down. What is the osteoblast? The osteoblast is a cell that is a progenitor to the osteocyte. In the same way that chondroblasts differentiate into chondrocytes as the cells get surrounded by the ground substance and matrix, the same thing happens with osteoblasts to osteocytes. The big difference, though, is that once an osteocyte gets trapped in calcified matrix, it is cut off from the rest of the world other than through the canaliculi. All right, so let's take a look at some of these in a little bit more detail. Okay, so now we're going to talk about how the cells work together to create a microscopic view of bone. Let me back up a slide, actually. So this is a macroscopic view of bone. Macroscopic view is the shape of the bone. It is either compact or it's spongy, typically is the binary system that we use. And remember that compact bone is referring to what I like to call the bone collar because it's located on the outer edge of the medullary cavity. The spongy bone is also known as trabecular or cancellous bone. So within both compact bone and spongy bone is our microscopic designation of bone. So in both, we have immature bone, also known as woven bone. In both, we have mature bone or lamellar bone. Now, let's take a look at the mature bone. So this is on the right here is the mature bone. This sure looks like compact bone, right? Why does it look like compact bone? Well, it's got the Haversian systems, right, which we talked about before. And for the most part, it is mature, right? It's the solid part of the bone. But between the osteons, right here in our interstitial lamellae, you will often find immature bone that is either forming to add to the osteons or being broken down. We tend to think of immature bone as becoming lamellar. Now, if we take a look at the immature bone here on the left, this sure looks like trabecular or cancellous bone, right? And that's because trabecular and cancellous bone has an incredible amount of immature bone. It tends to be more on the developing side, but that doesn't mean it doesn't have of trabecular or lamellar structure within it. Okay? In both mature and immature bone, we have osteocytes, osteoblasts, and osteoclasts. They're located in both. Now, if I were to take a look at compact bone, I'm more likely to see, in the compact bone, I'm more likely to see woven or immature bone in regions where I don't have differentiated lamellae or osteon structures. If I'm looking at trabecular bone, the place where I'm most likely to see woven or immature bone is going to be closer to the surface, closer to the marrow cavity on that bone where I've got my blood vessels. The reason why I look there is I look towards the blood vessels or the marrow cavity. That's where my osteoprogenitor cells are going to be coming from. That's going to be the youngest part of the bone. Okay, so here are some pictures of the same idea. Okay, so here we have W refers to woven bone. So we have osteocytes that are floating around. They're trying to lay down their matrix, right? You can even see that here where we have clear lamellae that are forming in these plywood sheets, but in between the lamellae, we have this unlamellated structure, and that would be the woven bone. Okay, so the key thing to remember is in both gross anatomical designations of bone, compact and spongy, we can have both woven or immature and lamellar or mature bone. All right, so here is some magnifications of bone. The one on the left is at a lower mag. You can see the Haversian systems and our cinnamon rolls. Can't see the raisins so well here in this picture. We can see Volkmann's canals cutting across different osteons. Okay. If we take a magnified view of one of these osteons, here's that image I showed you earlier with the Haversian system, our osteocytes. This is a special ground substance stain where you can see the black lines of the canaliculi, which are connecting the lacuna of the different osteocytes with the Haversian system. And if we focus in on a few of these cells, you can see there's spider-like projections coming from the lacuna with the osteocytes sitting smack dab in the middle of each of those lacuna. Very cool structure, very cool. Okay, so now let's turn our attention to the cells that are involved. The first one that I mentioned, if we talk about from development to maturity, the first one is the osteogenic stem cell or the osteoprogenitor cell. This is the cell that is most closely related to the mesenchymal stem cell. This osteoprogenitor cell will differentiate into the osteoblast. And it's this osteoblast which lays down the uncalcified osteoid or the uncalcified bone matrix. When an osteoblast is surrounded by calcified bone matrix, it differentiates into an osteocyte, which maintains the matrix within its lacuna and communicates with the marrow cavity, if we're in spongy bone, or with the Haversian or Volkmann systems, if we're in compact bone, via the canaliculi. These are the three main bone cells. Then we have this extra guy, the osteoclast, which is our multinucleated cell. It's a huge cell. It's big. It is not related to the mesenchymal stem cell line at all. It is not a connective tissue cell. In fact, this osteoclast is monocyte or derived from the macrophage line, which makes sense because guess what osteoclasts do? They chomp up bone matrix. And so just like a macrophage would chomp up bugs, osteoclasts chomp up bone matrix. And by the way, I'm not biased, but osteoclasts are one of my favorite cells. They're super cool. All right, so here's what's going on. The mesenchymal stem cell, via the vascular system, arterial typically, is going to find its way to the periosteum and also by penetrating into the endosteum. And so it differentiates into an osteoprogenitor cell, okay? The osteoprogenitor cell differentiates into the osteoblast, which when quiescent becomes a bone lining cell. So if it's laying down an osteoid, it's an osteoblast. If it's just sitting there doing nothing, it becomes a bone lining cell. If it's surrounded by its matrix, it becomes an osteocyte, which you can see here. So this is a cartoon migration of where these cells come from. The monocytes, which got there via, again, the vascular system, have these osteoclasts. Now on this cartoon, it shows the osteoclasts lining the marrow cavity. And for sure, there are many, many osteoclasts lining the marrow cavity. But there are also osteoclasts that are located just deep to the periosteum. They're just not in as much abundance, but they have to be there because they have to have also shaped the bone from the outside. As you can see here, this metaphysis is narrowing in a funnel-like manner towards the diaphysis. Well, you got to have osteoclasts on both sides of the bone collar to be able to shape the bone to look like that. So the general thought is the osteoblast is laying down the bone matrix. It gets calcified. So think of it like quick dry cement. It gets calcified and it forms, and it's formed. But it's the osteoclasts that shape that bone matrix that was laid down. So the two cells are working with but against each other in order to create the bone shape. All right, so we have 5 different cell types: mesenchymal stem cell, the osteoprogenitor cell, the osteoblast, the bone lining cell, and the osteocyte, which are involved in bone formation, other than the bone lining cell, which is just sitting there. But they are all derived from mesenchymal stem cells. The 6th cell, the osteoclast, is derived from the monocyte. And that's important to realize. Okay. So now, this slide just basically summarizes everything I talked about with the osteoprogenitor cells. So some things to know also is that osteoprogenitor, when the body feels like we need to form bone, and how do we know we need to form bone? Well, we need to form bone when the organism is growing, so that can be under endocrine control. But we can also form bone also under endocrine control when we have too much blood calcium. So if we have to remember, the bones are a big storage unit for calcium. So if we have to store calcium, it's going to stimulate osteoprogenitor cells to form and become osteoblasts. And we're gonna throw that calcium into the bone matrix. All right. So we tend to find them in around the periosteum. Here's our osteoblast now. Now this, what kind of bone is this? This is a trabecular bone that's forming. It's actually even probably before that. This is a woven bone where these osteoblasts are laying down their osteoid. So you can see that they're lining this, this cavity, this matrix. The osteoid is this clearing right here, and this pink stuff right here is the woven bone. And look, right around the corner is the osteoclast. Look how big they are. They're huge with multiple nuclei. So while these osteoblasts are laying down bone, this osteoclast is coming around to shape it. Now, if in the same way that if we need to build bone, we recruit osteoprogenitor cells to become osteoblasts. If we need to resorb bone or put more calcium into the blood, we recruit more osteoclasts to do that because they're going to be chomping up the bone, right? So we'll see how that balances out in a little bit. But notice that osteoblasts lay down the type 1 collagen and the bone matrix, and they also help facilitate the mineralization of the osteoid that they just put down. Here's another cartoon. Lots of osteoblasts located here. The darker pink is the bone, the woven bone that they're laying down. All right. This is more of the marrow cavity. We know that because we have some bone marrow cells located here and here. Okay, lots of osteoblasts. Now notice the osteoblasts are pretty tall, cuboidal. cuboidal is probably fine. I wouldn't call them, that's the shape, but I wouldn't call them an epithelium. But notice we have these cells here, which are lining the same part of the bone. Those are bone lining cells. Those are the quiescent osteoblasts that have not turned into osteocytes, versus another cell down here. This guy is going to become an osteocyte because it is surrounded by its matrix. Let's see, I don't see any osteoclasts on this picture, but if we take a look at the cartoon, you can see here again our osteoblasts and our osteoclasts are hanging out together doing the opposite thing, right? And then these are our bone lining cells right here. And our osteocytes, which have been trapped by their matrix. All right, so now here are some osteocytes in woven bone. It's not quite lamellar, and I don't know whether this is coming from compact or spongy bone, but given the amount of matrix, I'm going to assume that it's in compact bone. But you can see here that these cells are definitely surrounded by matrix. So they're not going to be laying down bone anytime soon, or they're trapped. So they're going to start boring or extending their cellular process to bore canaliculi, which will connect with this, let's presumably call it a Herversion system. Now, how does the bone stay alive, the bone matrix? These cells are keeping that matrix up. They're constantly giving the calcified matrix to that area to keep it hard, but they are not producing osteoid. So not laying down new bone. They're just maintaining the bone that's already there. Okay. Now, actually, there's one exception to that, and that is if there's mechanical stress, then these cells, we are not going to be able to get the osteoblasts to these regions. So let's say there's nanofractures, if you will, but super tiny cracks in the bone that need to be repaired. The osteocytes can repair that bone. So here is a nice picture again of the canaliculi that are communicating between the cells and eventually communicating with the Herversion system. You could call them spiders, you could call them raisins, whatever you want to call them. Now, what happens if an osteocyte dies? How do we get in there? Well, remember that osteoclasts can be hanging out here in the center of the Herversion system, or they can be hanging out on the outside of the compact or trabecular bone. And they will bore their way all the way through the osteon or the trabecula to get to that osteocyte and get rid of it. Remember, they're macrophages, essentially, specialized macrophages. Then the hole that's left behind gets filled in with osteoblasts, which fill in the osteon, and et cetera, et cetera. So hopefully what you've appreciated at this point is that bone is incredibly dynamic. We think of it as this solid structure, but these cells are working all the time to be able to resorb bone, lay down bone, resorb bone, lay down bone, and it goes on and on and on. All right, so here is a picture of the bone lining cells, and again, they're not doing much except for regulating calcium. Notice that they, as far as we know, they're not capable of mitotic division. They will convert back into osteoblasts when the time is needed for them to be recruited. One thing that I haven't mentioned yet is that these cells that are lining the marrow cavity and on the bone are connected by gap junctions. And so that's how they communicate with one another, and also can help signal when cells need to differentiate. All right, so those are the main types of cells that are involved with laying down bone. Just like the cartilage matrix, the bone matrix is comprised of a lot of collagen. But in this case, instead of type 1 collagen, it's comprised, instead of the cartilaginous type 2 collagen, it's comprised mostly of type 1 collagen. In addition to that, which we've talked about a lot, it has a lot of calcified matrix. Again, hydroxyapatite that forms from calcium phosphates. We do have some glycoproteins and proteoglycans, like I mentioned before, but it's such a small amount because the matrix is dominated by the type 1 collagen and the hydroxyapatite. And notice this, not much water in this. So this is almost the exact opposite of the collagen. All right. I should mention that the proteoglycans do contribute to the compression strength. So while they're not soaking up as much water, the little amount of water that they do hold allows the bone to be somewhat movable, and at least on a microscopic level. And then the glycoproteins are attaching the collagen fibers and helping the cells stick, so to speak, to the bone. All right, so now what about the osteoclast? Look at this bad boy, it's huge, right? So what you see here is woven bone underneath the osteoclast. This happens to be, that looks like dense irregular connective tissue. So this might be a developing bone collar. Osteoclasts are responsible for bone resorption. And now they can get kind of carried away, right? So if they are resorbing too much bone, that can cause an osteoporotic condition. But that may be because of the balance between how much osteoclasts are resorbing and how much osteoblasts are laying down, which is actually really more the story. So again, they're multinucleated. They are derived from monocytes, and that's super important. And they need to be activated in order to, their default is not to chomp up bone. Their default is to lay there quiescently, like this guy over here on the right. When an osteoclast is active, though, you have this huge clearing zone right here. This is where bone is being chomped up chemically and being absorbed into the cell, and the cell is going to kick it out into the bloodstream. Here's some more pictures of osteoclasts. Oh, they're just so cool looking. Macrophages in general are just neat cells. Again, they're typically on the surface of the bone. Here it is. Here's an osteoclast that's on the bone matrix, this woven bone matrix. Anyway, very cool. Oh, the little clearing underneath is called a Hauschup's lacuna, right there. We're going to see that in a second. Here we are. Here's a Hauschup's lacuna. This is what it looks like in cartoon. Now, on this image, I'm not holding you to the biochemistry that is happening here. What I do want you to know, though, are these three borders of the cell and what it is doing. So let's talk about the ruffled border first. The ruffled border has this increased surface area of plasmalemma, or plasma membrane, excuse me, that is there to exocytose low pH enzymes. So hydrogen, and then the proteinases that are going to break down the collagen, the type 1 collagen that is right here. Okay, so it secretes all of that right here. There's a clearing zone around the ruffled border as well, and that clearing zone contains actin, mostly actin filaments that seal up the chemicals being dumped into this Hauschup's lacuna, so it doesn't leak out and break down the bone around it. Okay, and then what happens is that the basolateral zone is going to do the exocytosis of the digested material. So the other side, so out here. So what happens is that we're going to secrete our enzymes and our protons to break down the bone matrix, and the osteoclast will endocytose the broken pieces of bone and will exocytose that out into the vascular system via the basolateral zone. Okay? So you do need to know about protons. You do need to know about chlorides, simply because that's where we get acids. And you do need to know about the enzymes, that it secretes enzymes in order to break down our collagen and our matrix. Very cool stuff. Okay, so how does this all work together? Now, if I had a developing long bone, if the osteoblasts had their way, they would develop the bone, and we'll talk about this in greater detail later, but they're going to start with the cartilage matrix and start laying down bone and essentially lay down a bunch of woven bone, which will become lamellarized. So in other words, going from immature to mature, and it'll be one solid mass of bone, right? Well, that's great, unless you want to like never be able to move off from the ground. So we need to have our osteoclasts that are going to bore holes through the center of the bone to create the medullary cavity. So let's see what this looks like if we just talk about one osteon. So here, this is a time sequence drawing where we call it a cutting cone. So here is a bunch of compact bone on this, this box of bone, if you will, that has been formed and lamellarized by the osteoblasts and maintained by the osteocytes. In this reversion system, we can introduce the osteoclasts. And so here's our osteoclast right here, okay? And what these osteoclasts done is they bored through and they are leading the cutting cone. So that's why you see them over here at the leading edge of the cutting cone. Okay, so they've bored through this osteon and have hollowed it out. Now maybe the osteoblasts say, okay, well, wait a minute, we need to close that back up. So they're actually in the trailing zone and they're closing the cone. See how they're closing it here? So you have to imagine that we start with this small hole, or the reversion system. The osteoclasts bore through it and create this big, huge cutting cone. And then in their wake, the osteoblasts come back and reform the bone. So what that looks like is we have an old osteon, or old part of the bone, that got cut away. And then towards the end, we have the new osteon that has formed, just like that. So how do we create the trabecular part of the bone? Well, what happens is that we just don't have a closing cone. So we have the cutting cone, which is the leading edge that's cutting through the bone that's been bored out. And then the closing cone just never really forms when for the medullary cavity, for the trabecular bone and the medullary cavity. But if we want to maintain the compact bone, we do have a closing cone, just like what we have shown here. Okay, so here are the typical steps. The osteoclasts drill a canal, the osteoblasts fill the canal, and some of those osteoblasts become osteocytes. They form lamellae, and then the process just goes on and on and on and on like that. So again, I can't emphasize enough that they work together in antagonistic ways to be able to get the job done. All right, so let's switch gears for a second. Here's some disorders of bone. So in osteomalacia, what we have here is that the osteoid that the osteoblasts are laying down and maintained by the osteocytes doesn't calcify. So you have a deficiency in vitamin D or calcium, which can cause these bowed legs. This is called rickets, colloquially. In children, the bones are soft, the legs bow. You don't have that typical structure. In fact, you can see here in the pelvis and the plates of the ilium that there's this radiolucent part, and that's because you don't have as much matrix in that region. Osteopetrosis is the opposite of what's going on there. So in osteopetrosis, what happens is that the osteoclasts are not able to balance out what's going on with the osteoblasts. The default, remember, for osteoblasts, unless they become bone lining cells, is to just build bone. Build. The osteoclasts, for whatever reason, are not able to balance that out and resorb the bone and resorb the calcium. So you have hypermineralization of the bone. You can see that here. Too much calcium located in the bone. The bones get really, thick. Now the question is, why is it that they get brittle? That's an interesting question, right? So if you don't have your osteoclast working to resorb the bone material, you've got a high bone density, but you don't have the opportunity to really put together or form these lamellar structures. So it's mostly woven bone, right? And so that's why the bone actually, even though it's got lots of mineralization, is actually not very strong. So now the bigger problem is the foramina close off and you get pinched nerves, and that's incredibly painful. In osteoporosis, here referring to bone holes, what we have now is that we have excessive bone resorption. Relative to the osteoblasts, the osteoclasts are more active. So now we're actually taking too much bone out. And of course, this tends to happen in elderly people. Here's an example of lumbar spine. You can see the radio-opaque parts of the bone. The spaces is where the intervertebral discs would occupy. But in osteoporotic bone, notice that the only part of the bone that actually still is radio-opaque is the superior and inferior surfaces. But the vertebral body in this case looks like it has a bunch of air. And that's because it's mostly really thin trabecular bone. All right, so we're going to end on this slide, and I want to challenge you to try to figure out why this character, Dr. Zoidberg, has anything to do with this particular lecture. So thank you very much for your attention. I appreciate it very much. I will see some of you in lab, and hopefully I'll see some of you in the review session. If you have any questions, feel free to email me. You can email me through Blackboard or jjwisco@bu.edu. That's jjwisco@bu.edu. Okay, thanks a lot. Thanks for your attention. Have a great day.